Okay, welcome everybody. Thank you all for coming. For those who I don't know, I'm Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. And on behalf of the school, welcome to today's seminar for everybody who's in the room, as well as who is online. So just to frame today's seminar, this is one of a series of our Dean's seminars on contemporary issues in public health, and there is perhaps no issue of greater contemporary concern than the opioid crisis. So in the US, about 64,000 people died from drug overdose in 2016. Opioids often were the reason. That's an almost 22% increase since 2015. The pace of deaths has now eclipsed those of the HIV epidemic at its peak, and just in Massachusetts, 38 people died last year from opioids. I apologize, 30 people died last week from opioids. These numbers suggest a systematic failure at the heart of the crisis. And as many people in our community know, I actually like stories. So just to tell a quick metaphor, imagine that there is a plague. And imagine that the plague affects everybody in society. It affects rich and poor, women and men, people of all races. Fortunately, the plague can be cured. But instead of administering the cure, we tell everybody who's sick with the plague that they are criminals. We blame them for their disease, and we give them prison sentences instead of medicine. We do this despite the fact that they are our friends, our family, and our neighbors. Now, what I'm describing sounds horrible, but in many ways, that is the status quo, what we have been doing for many years, dealing with addiction in this country. Fixing this means that we adopt data-informed approaches that trade punishment for treatment, stigma for the actual facts about addiction, a broad multi-sectoral coalition that includes law enforcement, academia, government, and the health sector. In academic public health, we have pursued this engagement by working with local, state, and federal partners, and it's the existence of these partnerships that sustains hope and points towards solutions. Today, our goal was to welcome speakers whose very presence reflects these partnerships. They will discuss how the opioid epidemic is being addressed at the state and national level. It's my honor to introduce our first speaker, Dr. Jerome Adams. Dr. Adams is the 20th Surgeon General of the United States. He is a board-certified anesthesiologist. He served as Indiana State Health Commissioner from 2014 to 2017, also was an associate professor of clinical anesthesia at Indiana University School of Medicine with an appointment in the School of Public Health. He has had leadership roles in a number of professional organizations, including the American Medical Association, Indiana State Medical Association, and the Society of Anesthesiologists. He is immediate past chair of the Professional Diversity Committee for the American Society of Anesthesiologists. As Surgeon General, Dr. Adams oversees the work of the U.S. Public Health Service Commission Corps with over 6,000 uniformed health officers serving in nearly 600 locations worldwide. Dr. Adams will be followed by Dr. Monica Burrell, a good friend of the school. Dr. Burrell is a commissioner of the Massachusetts Department of Public Health, where her portfolio includes spearheading the state's response to the opioid crisis. Her priorities include reducing health disparities, improving healthcare quality through the use of data, and evidence-based practices. Dr. Burrell previously served as Chief Medical Officer of Boston Healthcare for the Homeless, largest nonprofit healthcare organization for the homeless in the U.S. Dr. Burrell was the gubernatorial appointee to the Behavioral Health and Primary Care Integration Task Force under the Massachusetts Healthcare Payment Reform Initiative. She has also served on faculty at the Harvard Medical School and the Boston University Medical School, where she received her medical degree. Today's moderator is Dr. Jonathan Woodson, one of our own, former Assistant Secretary of Defense for Health Affairs, current Director of Boston University's Institute for Health System Innovation and Policy. During his time at the Department of Defense, Dr. Woodson was the principal advisor to the Secretary of Defense for all health-related issues and ensured the effective function of DoD medical mission. He had authority over the Defense Health Agency, the Uniformed Services University of the Health Sciences, the Armed Forces Radiobiology Research Institute, the Defense Center for Excellence for Psychological Health and Traumatic Brain Injury, and the TRICARE Health Plan. Before we begin, I just want to acknowledge we have a range of distinguished guests who are joining us today, and I want to thank you all for coming. Those include Provost Karen Antman, representatives from the U.S. and Massachusetts House of Representatives, Massachusetts Senate, City of Boston, and many other organizations who are all working towards finding an end to the opioid epidemic. I'm very much looking forward to today's discussion. I want to thank our guests, and I want to thank you all for coming. Dr. Adams.
Well, good afternoon, everyone. I'm a father, 13, 12, and 8-year-old children. I'm a physician. I'm a board-certified anesthesiologist trained in acute and chronic pain management. I'm the 20th United States Surgeon General. And I'm also the family member of someone who is suffering from substance use disorder. My little brother, Philip, is in state prison right now, suffering from still untreated substance use disorder. This has had an effect not just on him, but on our entire family. My mother at times has felt like a prisoner in her own house. For several years, she didn't come out to visit me because I was in another state and she was scared the TV would be gone or things would be missing if she left the house. It's cost my family physical ailments. They've had heart problems from the stress of trying to take care of him. And I share this story, as painful as it is, because it's important that we understand that addiction touches each and every one of us, that no one is spared, black, white, rich, poor, urban, or rural. And if we don't share our stories, if we don't do what we can to lower stigma, if we don't become better partners in this plague that the dean mentioned, we are not going to overcome this epidemic. So it's why I'm so pleased to be here today to address all of you and to engage in this conversation. And I hope it's a conversation, and I hope it's just the beginning of a conversation. And I want you to know that solving this epidemic is not just pressing. For me, it's personal. It's very personal, as it is for so many of you all. I'm going to take just a few minutes and go through a few things to help set the context for our discussion. I want you to understand, first of all, what the Surgeon General is and what I do and why I'm wearing this uniform. You know, I hopped on a plane yesterday morning at about 5 a.m. It's coming over in my Uber, and the guy in the Uber insisted that I was a pilot for the plane. And he kept asking me when I was going to fly the plane back from Boston to D.C. And finally, I just gave up and just went with it. And I said, yeah, I'm not flying back until Friday. But I'm not wearing this uniform because I'm a pilot. I'm wearing this uniform because one of my jobs as Surgeon General is to be head of the United States Public Health Service. 6,500 of the most dedicated individuals who are focused on public health in this country: doctors, nurses, pharmacists, environmental health specialists, and several of them are in this room. Can my public health service officers who are in the room stand up? Where are you? Thank you. I had the pleasure of touring Ellis Island over Veterans Day and learned that many of your ancestors are only in this country because the United States Public Health Service was there screening and vetting individuals so that we could protect our country as far back as 200 years ago. So thank you very much. From Ellis Island to Ebola, the U.S. Public Health Service has been there. As Surgeon General, I'm also known as the nation's doctor. And in that role, it is my job to educate the public about the science regarding health. And that's what I hope to be a part of today, a discussion to educate folks about the science regarding health. My overall theme of my tenure is better health through better partnerships. And I had this discussion with the students earlier. Whether it's relationships with your significant other or trying to solve the opioid epidemic, we've got to learn to be better partners. There's a saying that people need to know that you care before they care what you know. And I shared this story with a few folks earlier. Many of you all know me because of the HIV outbreak in southern Indiana. Small town, rural Indiana, 4,000 people, now 230 plus cases of HIV, all related to injection drug use. And I ask folks the question, as a doctor, as a public health advocate, who do you think I first called when they called me up and said, you've got an HIV outbreak in southern Indiana? And folks will say, the CDC, Indiana University School of Medicine. Did you call them? Did you call their infectious disease department? The three people I called were the local faith-based leader, the head of the local chamber of commerce, and the chief of police. And the reason why I called them before I called the CDC and before I called the infectious disease docs is because I knew what the science was, but I had to translate that science into policy. And the people who were going to help me translate that science into policy, science being what we know is true and policy being what we can convince the public to accept, were the economic community, the faith-based community, and the local law enforcement community. And I mentioned the local law enforcement community. Where are our law enforcement officers who are here today? Can you all please stand up? The rest of them are outside taking care of us, and so I thank them for that. But they are a critical partner in this fight to address the opioid epidemic. Because addiction is a chronic disease that requires a coordinated effort, and we must mount a robust response, but we can't do it alone. Anyone ever heard that saying, or been posed the question, how do you eat an elephant? How do you eat an elephant? One bite at a time. This opioid epidemic is an elephant. And we at times feel overwhelmed because we don't know where to start. Gosh, there's an elephant in front of me. How do I eat this thing? I can't eat an elephant alone. But if all of us in this room take a bite of that elephant, we'll have it eaten in no time at all. And so what we need to do is make sure we show each and every person where they can take a bite of that elephant and how they can intervene. We've got work to do, but I feel like we've at least started to engage the public health and the medical community. We've got work to do, but I feel like we've started to engage the law enforcement community. What we need to do a better job of is making sure we're speaking to the public, to the mothers, to the fathers, to the people out there in the community who recognize that this is an epidemic but don't know what to do. And so one of the priorities of my tenure is to continue to educate the public about the severity of the epidemic and what they can do to respond. A recent article came out based on polling from Dr. Bob Linden over at Harvard. About half of our country still doesn't believe that this epidemic is an emergency, and certainly doesn't believe that it's an emergency in their community. We've got to help them understand that this is touching each and every person. About half of people don't believe that Narcan should be available, Naloxone should be available for individuals without a prescription. I'm a trauma anesthesiologist, worked at a level 1 trauma center. If I were to go outside right now and find someone in the street who was bleeding, I'd apply a tourniquet. Even if I saw that their arm was broken, I wouldn't try to do the definitive surgery right there. I'd tie a tourniquet, stop the bleeding, and get them to that definitive treatment. That's what Narcan does for people who are suffering from addiction. We've got to help people understand that we have to apply that tourniquet, and we've got to get them to treatment. There's a lot of compassion fatigue going on out there. Folks are frustrated because they're hearing stories of people showing up over and over and over again with overdoses. But we've got to do a better job of getting on the tourniquet and then getting them to the definitive treatment. We've also got to help folks understand that addiction is a spectrum. It is a chronic disease. We wouldn't say if you, well, let me show you. I'm a chronic asthmatic. I carry my inhaler around with me. Sometimes I need to use this inhaler. Sometimes it gets so bad that I've got to go in and see my doctor. Do they say to me, well, gosh, you haven't been doing the things that you're supposed to do. Too bad you're out of the program. No more inhaler for you, Dr. Adams. We're not going to see you anymore. No, we don't. We recognize it as a chronic disease, and we've got to help folks understand that addiction is a chronic disease. We also have to talk to our prescribers and help them understand that they've got to be part of this. We will never be able to train enough people in addiction medicine to dig our way out from this epidemic. The only way we're going to do it is by galvanizing all of our primary care providers, all of our physician colleagues, along with all of our allied health providers, our physician assistants, our therapists, our nurses, our pharmacists. We've got to bring them into the fold, because if we can get all of them participating in the response, then we will be able to overcome. The final thing I would say as I've been around the last 2 days is I continue to hear frustration about lack of treatment options and about how to discern which are good treatment options and which are inappropriate treatment options. And I would suggest that we do need to do a better job helping folks understand the good and the bad. And there are a couple of things that I want you all to know that are part of a good treatment program. Number one, it's got to be personalized. It's got to be individualized. There is no one-size-fits-all approach. And if anyone's telling you there's a one-size-fits-all approach, then it's probably not a good treatment program. We need to make sure it's customized because every person's addiction story and recovery story looks different. Number two, we've got to make sure they offer the full gamut of FDA-approved medications and treatment options. Only 1 out of 3 treatment programs right now offers medication-assisted treatment, even though we know it's the standard of care. We've got to help folks understand that that's got to be part of the discussion in any person's recovery conversation. Yes, there are people who've recovered without MAT. There are people who've recovered from their diabetes without insulin. But that doesn't mean that as a doctor, I'm going to have a discussion with you about your diabetes without including insulin in that discussion. We've got to make sure behavioral health interventions are part of a recovery program. Because one of the other problems is we've got the new pill mills, the pill mill 2.0, folks out there who are just giving out medications and not giving the behavioral interventions that need to go with it. We need to make sure, again, that folks understand this is a chronic disease and that we're not just putting folks into detox and then kicking them out on the streets. And then finally, and I just had this discussion with Michael Botticelli, who's one of my good friends there and who's a leader from your community. You've got to have a full array of recovery support available. Because folks aren't going to be able to stay in recovery if they're worried about where they're going to live, where they're going to sleep, how they're going to eat, if they can pay the bills. We've got to make sure that all treatment programs connect folks to the support services that they know that they need. And so I've filibustered long enough. I want to make sure we do have a conversation, but I hope you detect just a little bit of my passion for this issue. And again, my passion for this particular issue is personal, but it also stems from the fact that I have a drive to make sure our society is healthier. And the only way we're going to get there is, again, by engaging those non-traditional partners and showing each and every one of you how it's not your problem, it's our problem, and how it's not up to me to come up with a solution, it's up to all of us to come up with a solution. And I'm convinced that if we all leave this room committing to do that, we will solve this opioid epidemic. And not only will we solve the opioid epidemic, but we'll deal with some of the proximate causes that help make us a healthier society in the long run. So thank you very much for that opportunity, and I look forward to continuing the conversation. Supposed to introduce Dr. Burrell. I failed. She's one of my good buddies.
Thank you.
You've got a wonderful, wonderful advocate for health in the state of Massachusetts. And did you bring up your Naloxone kit?
I got it down there. We'll show it together.
All right, we'll show it together. All right, because we want to make sure no one leaves here today without at least seeing a Naloxone kit and understanding how easy it is to administer Naloxone and save a life.
Thank you, Dr. Adams, and thank you for your national leadership on this topic, which has been important to many of us in the audience here for decades. So I was looking across this room, and you asked folks who work with you to stand. I won't do this, but oh my goodness, if I look around this room, the number of people in this room who have either been my mentors or are my mentees or who I hired into a position that they're in now or who I currently worked with or who we saw a patient together in the emergency room at Boston City Hospital or tried to find them a treatment program or who we gave Naloxone to on the corner of Mass Ave and Albany Street, or who taught me how to intertwine mental health with primary care, it's overwhelming. And what that tells me about this very, very special place is that many, many people in this room understand this issue deeply and have been working on the issues related to substance use disorder as the medical disease that it is for decades. And when I think about that, and I think about where we are right now, many of us, from my days at Boston City Hospital to my time across the street at Boston Healthcare for the Homeless, we've seen addiction for a long time. And we've seen co-occurring mental health issues. We've seen the devastating medical consequences of not only addiction, but the oppressive consequences of the social determinants of health. And what I see now is in Massachusetts, and really, as you heard from Dr. Adams, across the country, because of the wide expanse of this current opioid epidemic, we really have a call to action that goes beyond the medical community, beyond the healthcare community, beyond public health, to law enforcement, to education, to communities, to people in chronic pain, all looking to contribute to the solution. And before I get asked this question, I'll answer it. Why now? Well, there's a lot of reasons. And importantly, for those of you in this room, part of the why now is we should have done more. There should have been more done in the 1980s. There should have been done more in the 1990s, but we're here now. And for those of you in the room who are experts in the field, I urge you, this is an opportunity to have substance use disorder for the first time be treated as the medical illness that it is. And I ask you to use all of your energy to help that happen, because all of us together are what we can use this moment and the silver lining of it to do the work that needs to be done. The other reason we're talking about this so much now is just the sheer devastation and loss of life. We lose almost 6 individuals a day here in Massachusetts. Those are numbers. We know behind each one of those numbers is an individual who up until the time of their death has gone through immense and deep suffering. Those that we don't wish upon anybody. There's their family, there's the community, there's those of us who have cared deeply for them. We haven't seen this kind of rate of increase in death from a single disease in Massachusetts since the beginning of HIV. This is really devastating us across Massachusetts. Many of you have seen the numbers that we released from the Department of Public Health, and you know that this is an issue across Massachusetts. There's no community that's not affected throughout Massachusetts, whether it's rural, suburban, or urban, and all socioeconomic status. So as we talk today, and I'm really looking forward to the conversation we'll have with Dr. Adams and all of you, as we talk today, I want to talk to you a little bit about the state-level action plan that we've put in place since 2015, and many of you have been involved in that conversation. When Governor Baker asked us to make this our key public health priority back in 2015, he assembled a group of us as a working group. And from that working group, which, by the way, was multi-sector, and I think that was really key, it included those of us in healthcare, those people in recovery, people from public health, additionally, people from education, from law enforcement, et cetera. We came together and assessed the situation, reviewed the literature, talked to people in the community, and came up with an action plan. So there were 65 recommendations and a 19-step action plan. And since 2015, we've been implementing that plan across the state. And to give you a very high-level preview of that, the structure that we used for that is the public health structure of intervening in prevention, intervention, treatment, and recovery. When we think about prevention, of course there's primary prevention, and making sure that individuals aren't exposed to opioids in the first place is a key piece of our program. And this has included many campaigns that are directly to the public. One of the interesting things that we found, and I was really struck by this as we did our listening tours, was the amount of stigma that exists. Dr. Adams alluded to this in his discussion as well. Still, far too many people than I would imagine think of substance use disorder, this medical disease, as a choice or a moral decision or something somebody could have avoided if they just tried harder. And part of our discussion about this has been around this substance use as a medical disease, and that's why I keep saying it again and again. And we have also seen that part of the stigma is that individuals don't know that there are treatment options. Imagine a world in which people didn't know that if you have high blood pressure, there's antihypertensives for it. Or if you have type 1 diabetes, you have to stay insulin. That's really how we are with substance use disorder still in many parts of our state. And so part of our campaign around anti-stigma has been introducing individuals who are successfully in recovery and who are living fruitful lives on medication to assist them with this medical disease. Additionally, we've outreach and done a lot of work with education, both at the middle school and high school level, speaking to parents, helping them understand how to talk to individuals, and really having them understand this for the disease that it is. The other part of prevention has involved prescribers. The uncomfortable truth about this current opiate epidemic is that 4 to 5 people who use opioids say that it started with a prescription pill following the directions that were written on the pill bottom, whether it was theirs or their family members or something that they got from a friend or a family member. That's the starting point. So in the last few years, we have had unbelievable collaboration with our colleagues in the healthcare world about what to do about this. And one of the things I'm most proud of, through the voluntary contributions from our medical schools, including Dean Ontman and the other 3 medical schools in Massachusetts, we became the first state to guarantee voluntarily that every medical student who graduates from Massachusetts will receive education in how to balance the need for pain management with the potential opiate misuse. And from there, the dental schools followed, the PA schools, the nurse practitioners, and the social workers, and we continue that work. So really educating the next generation in education that you might get in school if you go to a place like this, and I had the mentors to do that, but many people didn't get that. And today's medical students, nursing students, dental students were saying, I don't feel prepared to answer these questions. I don't feel prepared to assess whether I should give this person opiate painkillers or not. I don't have enough training. So we really took that to heart, as well as working to continue education for those of us who are already practicing. We also worked on in our intervention area to improve the prescription monitoring program. I use the prescription monitoring program, the database of all prescriptions that an individual received. I used the old system all the time, and it really helped me in my clinical decisions, but it was hard to use. We went from 11 clicks down to 3. In a few seconds, you can now be in the system, and it gives you that clinical knowledge to help you decide what is best for a patient. We have over 58,000 users now using the prescription monitoring program, and we have delegates who can help so that the clinical flow isn't slowed down. Additionally, we have a 7-day limit on prescriptions. Massachusetts was the first, and several states have followed for first-time prescriptions. In the area of treatment, one other thing in interventions, which Dr. Adams spoke about too. You know, Massachusetts was one of the first states to have Naloxone available to family and friends, and the trainings that are done on how to use Naloxone began a decade ago here in Massachusetts, and now we have extensive programs for bystanders, so family and friends, as well as Naloxone use has been fully embraced by our colleagues in police and fire and is used successfully by first responders. And as prescribers and as pharmacists, we now have increased access for our patients to Naloxone. So we have really, across Massachusetts, making Naloxone available a key part of our response, and have no doubt about it, tens of thousands of lives have been saved because of that program. Finally, in treatment and recovery, there's a lot of work still to be done, but we've made progress. More beds than ever before have been added to our treatment system. Just in the Bureau of Substance Addiction Services alone, we've added about 700 beds. We're working with providers across the state. The program led by Colleen LaBelle on training for Suboxone use in offices is embedded in dozens of community health centers and provider practices across the state and is looked at as a national model. And we're working really closely with our federal partners to think about ways that we can address the supply-demand issues of medication. I will tell you one of the things I still see from individuals in the clinical world is a hesitation to think about medications for treating substance use disorder, this medical disease. There's decades worth of literature. Some of the people who wrote that literature are sitting here in this audience today. There's decades worth of literature that medications work for substance use disorder. If that isn't enough, in the state, we've been putting data together in new ways that showed that if someone presents with a non-fatal overdose and they get started on either buprenorphine or methadone, their risk of fatal overdose goes down by 50%. 50%, that's here in Massachusetts. Just imagine if that was a chemotherapy, a blood pressure drug, something that brought A1C down by 1 or 2 points. Everybody would have it, and we would all be using it. So I really would like us to think together as we open for discussion how we can take these facts, the facts are there, and turn them into action. Finally, I want to say, in the world of recovery, there's a lot to talk about, and many of us in this room, have seen people successful in recovery, but this is a lifelong disease, and we need to together make sure the resources are available, the housing resources, the support, the ongoing medication treatment that individuals need, the reintegration into society, including their care for often neglected medical diseases. At the Department of Public Health, we have taken a precision public health approach to how we think about this current opiate epidemic. For the first time ever in Massachusetts, we've brought together 20 different databases from across the state and are integrating that information to help us develop a deeper understanding and come up with solutions to this devastating epidemic. Just to give you a couple of examples, that data I told you about the medication, that comes from this Chapter 55 work. We have been able to highlight the groups at greatest risk from opiate overdose death from this data, and we have found that among them are individuals who are just being released from incarceration, who have hundreds-fold greater risk of dying in the days and months after they're released from both prison and jail. That data point alone has opened up new discussions and dialogue with the criminal justice systems in ways we've never had before. This cross-sector ability to have communication in a meaningful way to help address the issue. And we have several grants out to houses of correction who are now, for the first time, talking about using medication for individuals with this disease. Additional high-risk groups that we identified are individuals who are experiencing homelessness with a 30 times higher risk of dying from opiates. Additionally, individuals, women who are pregnant and postpartum, in the 6 months after they deliver, a marked increase in their risk for overdose death. And finally, individuals with severe mental illness. Many of us have treated individuals who have substance use disorder and mental illness. We're doing more work than we ever have before with the Department of Mental Health and the Department of Public Health to make sure that individuals get the treatment for all of the diseases that they have. So there's lots happening. What are we seeing? We're seeing a lot of overdoses still. There's still too many deaths. We're hopeful. In the first 9 months of 2017, we saw a 10% reduction in deaths compared to the first 9 months of 2016. It's hopeful and encouraging. Of course, we have a long way to go. We see the burden of opiates in the communities going down. We have 29% less opiate prescribing now compared to 2015. That's hopeful and encouraging. And you know, when I go across Massachusetts, I hear more people than ever starting to talk about substance use disorder as an illness, starting to understand that there's opportunities in treatment and recovery, and starting to embrace community members as the people who need the help from us that they do. So it's encouraging and promising, and I look forward to discussing about the next steps and how we can continue in this important work. It's wonderful to be here with you all today.
Well, good afternoon. I'm John Woodson. I'm going to ask the Surgeon General and Commissioner Burrell to join me up here on the stage. And as they're doing that, I want to extend my deep thanks to both of them. They're busy public servants, and they've taken time out to come spend it with us today and talk about this thorny issue. I also want to thank all of you. By judging by this audience, the response has been overwhelming, and so it means that we've got a community of individuals who are deeply committed to solving this problem, joining with our leaders to help find solutions to this problem. Just a couple of housekeeping notes. I would ask all of you to silence your electronic devices, and we're going to get you involved in the conversation in just a minute, and so I would ask you to write your questions down or think about your questions so that you can present them succinctly so that we can get to as many folks as possible. And so I want to begin the conversation by asking our two leaders here, understanding that this issue of opioid addiction and how to stem the tide is multifactorial, and that there are a number of components to addressing the problem. What are your thoughts about what we need to improve in prevention strategies, acute treatment services, stabilization services, residential recovery homes? And so what I'm saying is, what do we need to do to improve our strategy across the continuum of care to ensure that we provide access to care and we prevent relapse?
Well, that's a loaded question there. There are a couple of things that come to mind based on conversations that I've had just since I've been here in Massachusetts. Number one, I see folks, and I want to thank my medical colleagues for coming out. I see a lot of medical colleagues here. We need to make sure everyone is utilizing evidence-based practices. And that seems like a no-brainer, but far too many of our institutions and our providers are not utilizing the practices that the CDC endorses that we know will help prevent addiction. We know that simply having a protocol for neonatal abstinence syndrome, for instance, it doesn't even matter which protocol you use. Simply having a protocol cuts ICU stays in half. So why doesn't every hospital in this country have a protocol for how you treat neonatal abstinence syndrome? There's a lot of work we can do there and low-hanging fruit that I think we can go after. And I also mentioned recovery support services. And one of the things we're working on the federal level is trying to be more permissive with our Medicaid waivers and trying to encourage state innovation so that folks can provide not just treatment for addiction in the traditional sense, but an expanded definition of treatment for addiction that includes peer recovery coaches, that includes housing, that includes, again, job training, that includes the things that we know are critical components to success and that, if not provided, will increase chances of relapse. And then the final point I would make, and that I really think we need to do a better job of, to answer your question, we need to do a better job of talking to the average person, to the mother and the father. Because, 2 years ago, and Monica and I have known each other for a while, we were still fighting to get folks to accept that there's a problem. Folks may not believe there's an emergency, they may not believe that it's happening in their community, but they at least now acknowledge there's a problem. We're at the stage now where they're like, okay, so now what do we do about it? We've got to help arm those folks with actionable steps that they can take. And I'm not going to go into them right now, but there are actionable steps each and every one of you can take. Each and every one of you can go to your home right now and go through your medicine cabinets and make sure you don't have any opioids in there that you no longer need. And if you do, that you get rid of them. Because as Dr. Burrell mentioned, 4 out of 5 people who are using heroin say they got started with their or someone else's prescription opiates. Teens say it's easier to get a pill than what it is to get alcohol. So there are actionable steps that you can take. Share your story. We're working with the White House to create a forum where folks can share their stories online, because that will lower addiction. It's shocking. How many of you all in the audience, by raising your hand, know someone who is suffering or who has suffered from a opioid use disorder? That's powerful. That is powerful because it helps everyone else around you who didn't want to raise their hand and didn't want to admit it not feel so alone. That's the way we're going to turn this thing around, in my opinion. Dr. Burrell?
The continuum of care?
I think I touched upon a couple of things, and everything you say resonates. I was really struck, having come from a healthcare hat, when I went and spent a lot of time talking to individuals in the community, how much we can do to enhance general knowledge. Small things like I didn't know Vicodin were opioids. I thought Tylenol #3 was safe, right? So there's a lot of general education. I look to my colleagues in local public health to say, what can we do to make sure that individuals are armed with the knowledge that they have so that they can do something, ask the right questions when they're getting an opioid from their dentist or doctor. I remember a mom talking about how when her son was what many of us would call nodding off at the table, she thought, well, he's a teenager and he's getting sleepy. She was finding spoons in his room, didn't know how to connect that. So there's so many things we can do in really basic education that I think we all need to do more. And whether it's in our communities or at the bedside or whatever area it is, whether it's at our police stations, in any capacity that we have, all of us can educate more. We put out a campaign, Stop Addiction Before It Starts, from the Department of Public Health, because parents said to us, we don't know how to talk to our kids about this. How do you even start the conversation? And this gets it started. And the CDC put out a study saying that parents, children who hear from their parents or caregivers about the dangers are 45% less likely to use. So some of these seemingly simple things, or maybe if we think about this all the time, they don't come to our mind, those kinds of interventions can be really key. And then I look around the room at all the researchers and the minds in the room, and I think about the data that we're putting together. I mentioned the data sets that we put together at the Department of Public Health. Everybody who helped us, there was only 3 or 4 of us at the department working on it, and everybody who helped us came in kind. So it was a really strong public-private partnership of people donating their time and efforts, people from this institution and others. When I called Dr. Antman or Dean Galea and I said, do you have anyone who can work on this? They volunteered people, and their faculty were glad to help us because they were contributing to the solution. So there's so much we still don't know. We know about medication, but we don't know what treatment path is best for what kind of person. We have lots of questions to answer and lots of data that can get at those answers. When should people go into detox versus who's best for outpatient, how long, all of those things. We don't have, think about something like cardiovascular disease and how much we know about it and how little we know about substance use disorders. So that is a great opportunity too, particularly for this audience.
And Dr. Woodson, you mentioned the continuum of care, and as I said in my opening remarks, the continuum of care starts with stopping the bleeding. The continuum of care starts with putting on a tourniquet. The continuum of care starts with Naloxone. And there's a story that Commissioner Evans of the Boston Police shared with me just this morning. Said there was a person who had overdosed in the streets in Boston, and there was an ambulance right around the corner. And folks ran to the ambulance and said, someone's overdosing. Someone just overdosed in the street, and the ambulance didn't have Narcan on board. And someone came by and said, what's going on a bicycle? And it was a bicycle messenger. They said, someone just overdosed. And the bicycle messenger had a box of Naloxone and took out their box of Naloxone and saved a life. So the ambulance, the first responder in that instance, wasn't even able to save a life. It was the layperson, the responder who came by. You can save a life, and that's where the continuum of care starts. And with your indulgence, Dr. Woodson, I think it's really important for this audience here to understand what Naloxone is. Dr. Burrell, do you have the Naloxone?
I do. So I think by chance I'm walking around. No, this is just a demo kit, but I bet there's someone in the audience who's carrying Naloxone.
We're going to do this here. I'm overdosing right now.
I'm not going to squirt water in your nose.
Well, but show them how easy it is and
So many of you have seen these. So the old ones that I used to use, you had to flick off the different pieces and put it together. So this is the new one. You should know that, so it's super light, easy to carry. If you get bystander training, you get 2 of these. You should know that we changed the regulations at the state level so that now everybody can carry the 4 milligrams instead of the 2. We haven't talked about fentanyl yet, but fentanyl often requires multiple doses. Someone's down, you understand they're unresponsive, you think it's an opportunity to use naloxone. There's this one thing here, and and that's it. And you've potentially saved a life in their nostril. Did I not say that?
No. And the signs and symptoms of an overdose: non-responsive, shallow, labored breathing, slow breathing. That's actually what kills most people from an overdose is depressed respiration. So either lack of breathing or shallow, slow breathing, but it's that easy. You can each save a life and be the start of a continuum of care and get many more people on the pathway to recovery. Thank you for indulging us.
No, no, I didn't know you were such a great act together in terms of, we would have put more stage area out there for you. Listen, I want to transition to another question. We've talked about sort of evidence-based treatment, a little bit about the continuum of care. But we understand that in order to be successful, there are a number of wraparound issues that we need to deal with. Sort of alignment of things like housing, employment, childcare, legal issues, financial counseling. How do we deal with this? And before you give a response, I had an opportunity to talk with Chief Ryan in the green room, and I was very impressed with his approach as a chief of police to this issue. And I don't want to put you on the spot, Chief, but maybe you could give us a minute or two on your philosophy about this problem and how you approach it.
Certainly. Thank you, Doctor. Okay.
Oh, they've got a micro. She's bringing you one.
We have a microphone? Okay. So again, Fred Ryan, Police Chief in Arlington, co-chair of the Police Assisted Addiction Recovery Initiative. Thank you, Doctor. It was indeed an interesting conversation. I'm also here with co-chair John Rosenthal of PARI. And we held a conference here, was it a month ago, 6 weeks ago, John? And we had over 300 law enforcement officials from around the country talking with, it was fascinating. We had a panel of medical doctors talking about medication-assisted treatment options with cops and the advantages and disadvantages of different medication-assisted treatment options. And as Dr. Adams said, the fact that there's no one size fits all. But to get to specifically answer the question, you know, we've done a lot of work around the country, particularly here in the Commonwealth with the commissioner and the governor, around changing the conversation from arrest and incarceration to treatment and prevention. And that starts with that every non-fatal overdose we are seeing as an opportunity now to get somebody into that continuum of care that Dr. Adams is talking about. And in our experience, it was really a situation of we didn't know what we knew. And for those of you who have seen the CompStat meetings in law enforcement agencies, you go over data and crime trends and try to come up with preventative strategies. And we have a particular brilliant young lady as a crime analyst who was sort of soft-spoken, and she was trying to get in on the conversation. This goes back a couple years ago. And finally she said, you know, Chief, can I chime in here? She said, yeah, please. And she put up a spreadsheet. And the spreadsheet had hundreds of names. And she looked at me as if I was stupid, and so she's a smart woman. And she said, I think we know who the next people in our jurisdiction are that are at highest risk of fatally overdosing. And of course, you know, there they were on the spreadsheet. And I said, who? And she said, they're right there in the spreadsheet, Chief. These are all people that we responded to and delivered naloxone to. We need to seize this as an opportunity. So now we have social workers embedded into the police department with the support of the administration who do outreach and prevention and survival planning with the naloxone, and then long-term intervention planning. And we try to get the mindset of the family to treat their loved one who's suffering from substance disorder no differently than if they were expecting a child. You would have a robust plan in place if your loved one was expecting a child. Who's driving to the hospital, bag packed, you know, cigars, doctor, you know, the whole 9 yards, right? Take that mindset to your loved one with a substance disorder, because when that window of opportunity presents itself to get them the help and they come for you, you begin the planning then, you've lost your opportunity. So that's been our approach, and thank you,
so
Doctor.
much. And
Thank you for the time.
And I do want to acknowledge that we have Deputy Commissioner Cotter in the room for Boston Police, and we've had some conversations with Commissioner Evans, and I'm overwhelmed at how thoughtful our law enforcement agencies are about this problem, so thank you. Doctors, what about this issue about these wraparound issues of housing, employment, child care, et cetera? What do we need to do? So you talk about we need to build better health through partners. What are your thoughts on this?
I'll be very brief here because we've talked about it already, but I want all of you to understand how important housing is. When you look at the evidence, one of the #1 predictors of success in recovery is whether or not folks have permanent supportive housing. One of the #1 predictors. So we have to do a better job on the federal level with Medicaid flexibility, on the state level and on the local level of making sure that is part of everyone's recovery plan because it is one of the #1 predictors. #2 is touch points. We need to make sure those wraparound services that we've already mentioned and that we don't need to belabor are available at each and every touch point. And what are those major touch points? The hospital ER when they've overdosed. Make sure you've got wraparound services available right there because as the chief mentioned, if they disappear, the next time they may be showing up at the morgue. We've got to make sure they're available when they're released from jail or from prison. That's another major touch point so that we're not throwing them back into the arms of the dealer. We've got to make it easier to get help than what it is to get high. Right now, you know the top 2 places for a drug dealer to hang out are right outside the jail and right outside the hospital ER. Because you've got a bunch of folks who are withdrawing, who then we throw back out in the public without any support whatsoever. And then syringe service programs. Those are another great touch point. And folks ask me how I was able to get a syringe service program started in conservative Indiana. Well, it's because we made it about so much more than syringe service programs. We made it about connections to health insurance, about connections to addiction and recovery support services, to connections to medical care. We need to provide those wraparound services at those touch points where we know people are most vulnerable and where we know we can have the biggest impact.
I think you touched on the key points. You know, this is mentioned, the chief mentioned it about catching a person when they're in that moment where they can receive help. And that can be in lots of different environments. Here, one of our 3 pilot programs of having an urgent care type model is here at BMC, run by Dr. Bernstein and his team, where when somebody comes in, if they're ready to accept treatment, they're started on it then. It's a new model, and we're looking at it in 3 different areas in Massachusetts, because it's this concept of when someone comes in and they're willing to accept care, can we give it to them at the point where we're seeing them. You know, whether it's on the side of the street, like Jim O'Connor and our colleagues at Healthcare for the Homeless are now going to be working with a van with our AHOPE colleagues to look at getting people interventions where they are. You know, it's about catching people where they are. The wraparound, which I actually call essential services because I think of housing as health, is really about, and we have multiple different examples in Massachusetts, mostly grant runs, many supported by the Department of Public Health, many supported federally by SAMHSA and CDC and others, are really about making sure there's case management involved, there's housing support services, employment support services, as well as recognizing the key role of peer recovery, recovery coaches, and community health workers to help people along this course. In some ways, I think about it when we always are so pleased when we have our Ryan White funding, because there's the medical piece of it, but then there's everything else that we need to do to help people be successful in their treatment. And it's a very similar kind of thinking about how do we incorporate all of this for a person who needs it, because again, the medication and the counseling is needed, but it's a small part of what they need.
What are your questions? You have questions from the audience?
Over here.
Okay. We have a question over here. Yes.
So this question comes from a Times op-ed that I read last year. In Kentucky, the sheriffs have experimented with doing a full treatment, you know, a 6-month treatment in the prisons, and they claim great success with it. I don't know how familiar you are with that program, but it occurred to me as both of you were discussing okay, people who just get out of jail are the most vulnerable, and these are all the things you need. And the prison provides, the program that they had provides every single one of the services that they need. And I'm wondering, no, including housing, including employment training, the whole 9 yards. So what are your thoughts on that program? And if it's a good thing, is it something that we should look to expand?
Could you, I ask you, identify yourself when you ask a question?
I'm sorry, I'm Andy Brand, and I'm a neighbor. I live in the community. I'm not a medical professional.
Thank you so much, Andy, for that question. And those are exactly the type of programs that we need to continue to support and lift up, and why it's so important that we have the law enforcement community engaged. There are programs like that in Massachusetts, programs like that in Indiana. The challenge is these programs are expensive. And we've got to figure out both which components of these programs are critical and how we can deliver them to more people at a lower cost so that everyone can have them available. One of the problems with the jails is that the jails are locally funded. So the jails that tend to have these programs are ones that are in more affluent areas or ones that can get grants. But one of my concerns about the opioid epidemic is that we are at times possibly setting ourselves up to worsen disparities if we only allow the interventions that we know to be effective to be applied to certain communities. And so, to answer your question very directly, it's a great program. We need to figure out how we can do more of it, and we need to make sure that such programs are available to everyone and not just the folks in the most affluent communities who can afford such programs.
We're going to hold on to follow-ups because we have so many others. We had a question over.
Yes, good afternoon. My name is Evandro Carvalho. I'm actually a state representative in Boston, Massachusetts. Good to see all of you. Thank you for being here, Doctor. This question is for Dr. Adams in particular because this debate is happening in Massachusetts now, and I know the commissioner probably has some take on this, but I want some, what I'm calling an objective, out-of-state point on this. What do you think of the safe site areas where folks can go and inject themselves for drug use, essentially? As you talk about wraparound services, that's something that you see. And I know, obviously, I think it's against federal laws as well, but without that, in your medical opinion today, what do you think about that?
Well, that's a great question, and it's along that spectrum of harm reduction. Syringe service programs fall into that same category, that same spectrum of harm reduction. And I think one of the things that we can do, particularly in this audience, is make sure we're critically evaluating the programs where they take place. It's very important that we continue to allow state innovation and allow the decisions about what does and does not happen occur at the state level. It's important that we evaluate them so that then we can go and share the science, because that's how we've seen Kentucky go from 0 syringe service programs to 50. That's how we've seen Indiana go from 0 syringe service programs to syringe service programs in many areas across the state. Because places like Massachusetts and New York and California were, quite frankly, leaders, and thank you all very much for doing that, but then also because you followed it up with the evidence, so that when I'm out across the country trying to promote these sorts of initiatives, I can say it's based on the science. It's not just something we're doing because we think it's right, it's something that we're doing because we know it's right. So specifically to your question about safe injection sites, we still don't know what those are going to look like in the long run. It's still a controversial intervention, both for many people morally, but also scientifically. One of the things I learned about syringe service programs, and I'll be very brief here, is that they look very different in rural America than what they do in the urban East Coast. I've had this discussion with Tom Frieden before, and folks challenged me about the difficulty getting syringe service programs in Indiana, and I tell them, New York City has more syringe service programs than probably anywhere else in the country, syringe service program sites in their city. But I guarantee you, if you go up to the average person in New York City and ask them where the nearest syringe service program is, they couldn't tell you. It's something that they're oblivious to. I can tell you everyone in Scott County, Indiana knows exactly where that syringe service program is and sees themselves intimately connected to it in that rural community. So we have to understand that we've got to have the science, and then we've also got to figure out how we implement that science, turn it into policy in different environments, and that's where you all can help us. And I hope that answers your question, and I hope you continue to push for evaluation of these programs here so that we can either say definitively that yes, they do work, or no, they don't work, and here are the circumstances under which they can be successful.
We have a question in the back.
Hi there, my name is Bill Beckman. I am a pharmacy, compounding pharmacy up in Beverly, up on the North Shore. One of the things we see up in our practice is a lack of coverage for different types of medications, primarily compounded medicines like I do in my practice, and we're trying to develop products that do work for pain without being opioids. How are we best served by trying to seek funding or mandated coverage for these types of products to eliminate the need for opiates and opioids initially?
Well, I would say at the federal level, I speak frequently with Dr. Scott Gottlieb, who's the head of the FDA, and he is committed to making it easier, making the approval process easier so we can get products out on the market more quickly. And also spoken with Seema Verma, who's the head of CMS, who's a good friend, and we all want to make sure that non-opioid alternatives are covered, not just non-opioid medication alternatives, but there are other types of therapies that we can use to treat pain. What I would say we can most effectively do in this room is making sure we're engaging the pharmaceutical and the corporate side as partners in this fight against opioids. There are a lot of folks who want to demonize the pharmaceutical industry. And make no mistake about it, they played a role in this opioid epidemic, a significant role. So did doctors. So did our law enforcement attitude that looked at it only from a criminal point of view. We all share blame in this, but the pharmaceutical industry and the corporate world are going to be important partners if we're ever going to be successful, because they're the ones who are really going to lead the innovation in terms of alternatives. Dr. Burrell, thoughts?
I just wanted to quickly add to that. In Massachusetts, we have a drug formulary commission run by the Department of Public Health, where we have lists of non-opioid alternatives and also lists of abuse deterrent meds, and are collecting information on issues such as this, as well as talking and doing advocacy at the federal level about the pricing issues.
We have a question here in the front. Yes. Yes.
Can you hear me all right?
It's right there, yeah.
Great, thank you. I took your advice and I wrote my question down because I kept adding to it as everyone was speaking. Thank you all very much. My name is Linda Hurley. I'm the CEO of a large medication-assisted treatment program in Rhode Island called Kodak. We've been in business 40 years. I've been in the field 30 years. And I am absolutely an advocate of medication-assisted treatment, obviously. So I'm thanking you for the work that you're doing. I have a specific question because it's one that's emerging. We have an aging population across the board. We know it. Those that are receiving medicine for their opioid use disorder are aging. And then we also have pain-related conditions that are represented in an aging population that are also coming to our doors with opioid use disorder. So they've aged themselves into Medicare. And all the flexibility in the world that we can get through a CMS waiver is not going to help us with this population. So I think my specific question is there a conversation right now about continuity in payment funding streams? Because also speaking about continuum of care, one of the issues that we have, and I believe Rhode Island's quite progressive, we're very fortunate, but one of the problems is that our continuum of care gets fragmented because different funding streams have different requirements, different criteria. So you can come this far and we want to do this for you and there's no funding for it. So I guess specifically my question is there a plan to address continuity or payment strategies that would allow true continuity of care for all populations?
The short answer is yes. Continuity is always a concern for me as a health provider and as a public health advocate. What I would say is that if it's FDA approved, then Medicare will certainly consider it and wants to pay for it. And so the challenge, I'm going to flip that question around to everyone in here, is we need to make sure the studies are out there that show that the medications used in settings are appropriate for individuals across the spectrum, because as you mentioned, our population is aging, and we need to make sure they're there. And I can tell you that Dr. Gottlieb and I are both going to continue to push to make sure that full array of treatment options is available for everyone, and that we're going to work with Stigma to make sure that, that if they're FDA approved and if the evidence is there, that we are paying for them.
Dr. Burrell?
Just a quick note on elders in general, just to think about that, because you raise an important point. One is that when we looked at our prescription monitoring program, maybe many won't be surprised, but the individuals who get the most opioids in Massachusetts, I'm sure it's similar in Rhode Island, is the 50 and above group. So whether that's their own direct needs for pain or potential medications left around, we're trying to remind people about education around pain pills and what to do with them after they've used them, so highlighting that. We've also done a lot of work with our long-term care facilities in Massachusetts, trainings and capacity building around how to treat and assist people with substance use disorder. And you know, that's a learning process because it's new for them to have to work with medication and medication-assisted treatment, but we're on a learning path with them.
So the hour is getting a little late, and I want to get to at least two other questions. I have one here in the third row. Is that correct?
Thank you. I'm David Rosenblum from the faculty of the School of Public Health, and thank you both for coming. You both spoke eloquently about the need for medication-assisted treatment as the standard of care. You also said that only 1 in 3 treatment organizations offers this. Most of those treatment agencies get public money. Why does SAMHSA and why does the Massachusetts Department of Public Health continue to send public money to organizations that refuse to offer the standard of care? Why is it okay in Massachusetts for the largest mandated treatment program in Plymouth County? Why is it okay for the Secretary of Corrections to announce proudly in this morning's Globe that he will not allow Vivitrol, buprenorphine, or methadone into this program?
I will let Dr. Burrell answer for Massachusetts. but I will say very honestly that you ask a fair question, and I explained before that we need to do a better job of making sure folks understand what is good treatment, what's evidence-based, and what's not, and paying for it. Here's the very real challenge that we face, is that folks are saying there's just not enough treatment, period. And so right now, what we need to do is make sure we're helping folks understand what evidence-based treatment entails, and then increasing capacity so that there are options out there that enough of those folks who are doing the right thing, that folks can get their need met. But from a pragmatic point of view, there are a lot of folks out there, taxpayers, who would say, I'd rather have non-MAT treatment available to my child who is suffering from opioid use disorder than no treatment available to my child with opioid use disorder. And we've got to do a better job of making sure that good treatment options are available for everyone so that they don't have to make that choice between so-so and evidence-based, that everyone deserves and should have access to evidence-based medication across the board. That's my belief, and that's what I'm fighting for. And I thank you for saying that and keep pushing for that. And I think everyone needed to hear that and needs to keep pushing for evidence-based, full array of FDA-approved medications available for everyone who needs treatment.
Thank you for raising that point, because it's a fair one. But you know, it's been very interesting for me, because when I came into the department, I said what you said, hey, we don't have enough, you know, people can't get into programs if they're bringing their buprenorphine. In Department of Public Health, Bureau of Substance Addiction Service licensed programs, in the regulations, it says that they must provide access or treatment with all the evidence-based medications. It doesn't have to be on premises, it means access to. The problem that we have is that, number one, not everybody knows that. We have now reiterated that in 3 different guidances. I'm happy to provide anyone with them that have gone out to all of our licensed providers. Another issue is that patients and family members as advocates don't know that. We have reiterated the need to post the complaint line so that we at the Department of Public Health can hear when individuals are being turned away or are not getting access to that care. So, part of it is what led us to this point, and I don't want to call it a philosophy, but sometimes incorrect understanding of what is required. And all of our regulations point to the need to access to medication. I want to just turn it back around for one piece of it. When you look at methadone for substance use disorder, it can only be prescribed through very strictly regulated opiate treatment programs. It is very hard in Massachusetts, next to impossible, to find a community that is willing to take a new OTP, as they're called, in their community. We as community members are part of this problem. It is very hard to expand the opportunities for treatment because people do not want these places in their backyard, if you will. Second point on that, I'm sorry, but it's a good question. Second point on that is there are not enough of us. We have, don't quote me or tweet me on these numbers, but we have over 25,000 physicians, if you will. I don't have the exact number in my head. Here, holding licenses in Massachusetts, we have like 1,600 of us who have DEA X numbers. My physician colleagues in the group, we need more people to be willing to do the training and to treat individuals with the medication that's available. So there's lots of different aspects to that. We definitely need to do more together.
We're just about out of time. Dr. Samet, you can have the last question. We could go on all night, I know, but we'll have to end someplace.
Jeffrey Samet in the Schools of Medicine and Public Health. Just a brief follow-up question to Dr. Rosenblum, which is, it is hard to place methadone programs, but you go to Canada, you go to Great Britain, you go to Australia, and methadone is not only available in these, which are very helpful, methadone programs, but methadone's available in physician offices and available in pharmacies with physician prescriptions. And there's not an evidence-based reason why that's not the case in this country. It's more of an anachronism that I think we need to get beyond that point. Your thoughts?
Well, I'll end where I began, that here's science, here's policy. We need to do a better job of helping folks understand what we know to be true, and then turning that into what folks are willing to accept. Because at the end of the day, when you're talking about taxpayer funding, well, there's lots of examples of us not going by the science. If we went by the science, we'd close every fast food restaurant around. And I don't mean that to joke or to dismiss what you're saying. I'm saying we've got to do a better job of communicating with individuals about the science and helping them understand how we can be part of the solution and not just expect that just because the science says so, that a community is going to accept it and that taxpayers are going to be willing to fund it. And that's what I want to work with all of you all on, to make sure we can continue to fight for good evidence-based programs and show communities how they can incorporate them. And the law enforcement community has got to be part of that discussion, because it means a whole lot more to that community who doesn't want to, you know why they don't want a methadone clinic in their community? Because they're worried about the public safety aspects of it. So when the police chief shows up and says, I think we need this in our community, and I think we can do it in a way that protects the public safety, that carries a whole lot more weight than when I show up as the doctor who says we need a methadone clinic in our community. We've got to be better partners, and we've got to do a better job of promoting evidence-based practices, and if we do that, we will get to where we ultimately need to be. I'm convinced of it.
Dr. Burrell, the last
And
word.
I think on that note, in the audience, there are clinicians, there are researchers, there's community activists, there's family members, there's friends, and don't forget your advocacy hat. So this point that you raise is about a piece of federal regulation that's really not been fully revised since the 1970s, and it's our advocacy. We as an administration, Governor Baker sent a letter to our federal partners urging thinking about the way that we use methadone in this country. We all have a voice in this, and we all have a role to play, and whether it's a small step or a big one, it's a really important voice to have.
So this has been a wonderful conversation. I'm going to ask Dean Galea to close us out here.
So let me just make a couple of quick comments. Commissioner Burrell was very kind to note there are a lot of people in this room who've done seminal work on drug overdose. And I want to read a line from a sentence, a line from a paper on drug overdose that some folks here wrote, and I will not name who they are just not to embarrass people. And the line is as follows. Efforts to equip drug users to manage overdoses effectively, including training in first aid and the provision of naloxone and the reduction of punitive police involvement in overdose events, will have a substantial impact on overdose-related morbidity and mortality. Now, I think you'd all agree that that sentence concords exactly with what we heard today. That paper was published in 2004. That was 14 years ago. And so I actually think that one of the big things that this panel highlights is how hard it is sometimes for us in public health to move policy to do the right thing. I think, Dr. Adams, your point about science being here and policy being here is very effective. And I would hope that apart from saving lives of the 60,000 people who are dying from overdose every year in this country, we learn from this so that we avoid other epidemics like this one, which now is higher peak than HIV at its peak, firearms at its peak, and car accidents at its peak. And if we can learn from this, both help people now, but learn from this to make sure we do not fall back to stigma and other conditions, and make sure that we do not have such lags between the evidence, what we know we should do, and what we're doing, I think we'll have done the world a real service. And I really want to thank our panelists for helping us see that today. So 3 thank yous. First of all, the panelists. Let's thank the panelists. It seems natural. A quick thank you to the staff at the Institute for Health Systems Innovation and Policy, as well as the School of Public Health, for making an event like this happen. It takes a lot of work. Thank you. And a thank you to all of you. Thank you to all of you for being part of our community, for being part of this conversation. And thank you all of you for what you do every day towards making the public healthier. Thank you for being here.